This is wonderful. We are so pleased to have you. I hope you get a lot out of this day and really realize how important our voice is as nurses for legislative advocacy. I'd also like to thank Janet Wall and her staff. They are incredible. They make this all happen behind the scenes, so please give them a round of applause. Thanks to Janet and the VNA staff. Before our first speaker joins us, we're going to have a little bit of a change in the agenda. The First Lady of Virginia will be with us, but she'll be with us in the afternoon or a little bit later. So just a little change in the venue, but she will be here to give us some remarks. So before our first speaker joins us, I'd like to take a moment to reflect on the really, really incredible importance of being a strong voice for our profession and our patients. Every year, the Gallup organization asks Americans to name the profession with the highest honesty and ethical standards. In 2015, nurses topped the list, and we have for the past 14 years. So the public really looks to us as a voice of the advocacy for patients, and you know, as you work with patients at the bedside or in clinics or wherever, that we really are the voice for keeping them safe. We must not waste this faith our patients and communities have in us, and we must become advocates for our profession. From state legislators to the White House, nurses have a unique opportunity to lend their expertise in influencing policy at all levels of the government. Who better to speak about the needs of patients than nurses? Who better to understand the needs of the nursing profession than nurses? I always say to my students, you will be the expert for any legislator who's out there. They don't know what we need, and oftentimes the legislators will have constituents come to them and ask for bills to be put forth, and really we need to be there to assure that whatever people are asking is really in the best interest of our communities and our patients that we serve. The VNA, along with the American Nurses Association, works to ensure that interests of registered nurses in Virginia are heard by our elected officials who lack true knowledge of the issues facing nursing at the bedside. Whether you work in the hospital, the clinic, the community, in the operating room, doesn't really matter. Thomas Jefferson said, "We in government do not have government by majority. We have government by the majority of people who participate." You represent the largest single group of healthcare professions in Virginia, in the state of Virginia, and really can be an incredible voice for positive change when we put our voices together. I know I was just talking with Kim Nelson a moment ago, and she was over in a subcommittee and just felt like, wow, this is just an awesome opportunity. So for those of you who are going to join us later on to go up to the General Assembly, it'll be a great experience for you. Well, it is my absolute pleasure to introduce our keynote speaker this morning, Dr. Marissa Levine. Our keynote address is always presented in memory of the Honorable Emily Couric. She was a state senator from Charlottesville who died in 2000 after battling pancreatic cancer. Senator Couric was a friend of nursing for sure and an advocate for nursing education. Her lasting legacy is the example she set, one of tireless work on behalf of her constituents and unparalleled grace and courage in the face of a devastating illness. It's really my pleasure to introduce Dr. Marissa Levine. Dr. Levine has served as State Health Commissioner since March of 2014. Prior to this role, she held the positions of Chief Deputy Commissioner for Public Health and Preparedness and Deputy Commissioner for Public Health. Oh, sorry, got it twice there. You really are important. Got him twice. Dr. Levine directed local health departments in 2 districts within Virginia and is a board-certified family physician and has a master's degree in public health. Please welcome Dr. Marissa Levine as she challenges us to imagine what our communities would look like. Thank you, Marissa.
I really do need you to be awake because I'm going to ask for your help this morning. And I'll just second the advocacy piece. Those of you who have not been over to the General Assembly, please go. Health policy matters. I heard a yes. Health policy really matters. It impacts more people's health and well-being than anything we as healthcare providers do, believe it or not. I'll try to make that case, and I don't mean to minimize it, but we want good public health policy. We want good policy in general because most policy impacts health. So I'm really honored to be with you here today. I don't know if my slides are available. I do have quite a bit of information. It would be helpful to have them, but while they're coming up, let me say a few words. I'm really humbled to be here to speak as the Emily Couric address. I didn't know Emily, but if you think of degrees of separation, in doing my homework, I realized that when I trained at the University of Virginia, I trained with George Beller. Does anybody know who George Beller was in relation to Emily? So Emily remarried George Beller. George Beller's a cardiologist, and I trained with him. I didn't know this at the time, but I may have certainly bumped into Emily when I was at University of Virginia. And I've read about Emily, and I'm really honored to be here in her memory and address you, because I think the spirit that she brought to the work that she did, and many of you know that she was running for lieutenant governor when she found out she had pancreatic cancer and had to withdraw. But everything I read demonstrate a person of tremendous spirit and courage. And that's really what we all need right now, because I think that we have a time of great opportunity, and the opportunity won't remain. The window's open, so to speak, but it's up to us to make sure that we each do what we need to do. And each of us carries a really critical piece of this puzzle, and I think that at the end of the day, it'll be about taking very specific actions with intent and focus to bring about lasting change. And the lasting change really ought to be about the things that I know you care about the most, is health and well-being for the people that we serve. Does anybody disagree with that? I think you all get it. Relationships are the key. Relationships are key to nursing, and relationships are the key to everything I will tell you today. I think you're all asleep. Okay, so here's what I'd like to ask. I'm going to go through a lot of information. You see the title here. It's about designing healthy communities. And I asked you in the program to imagine what a community would look like if it was intentionally designed to bring about health. I want you to think about your own community. For those of you who are trying to get credit, I do have educational objectives, because at the end of the day, I want you to know more about what's actually happening in Virginia. I think I'm getting a clicker. Great. And I have an obligation as the State Health Commissioner to tell the story of the people of Virginia. Now, I would love to be able to do that and tell you that I have a relationship with 8.4 million Virginians, but I don't. I have met many. I'm honored to be here with you today. Thank you very much. And hope to meet some of you. But at the end of the day, what I'd like to do today is tell the story of the people of Virginia through their data. Each data point represents a person, and many of those people are people you have interfaced with and touched their lives. So as I tell you the story of Virginians through the data, don't think of the data as just numbers. Think of them as the people that you know, your friends, neighbors, and the patients that you've served. And then I'd like to focus on describing approaches that you can take, that we can take collaboratively as we move forward. So I'll do that by showing you a lot of information about Virginia, some that you may have seen and some that you may not. And some of it I think will be very telling. And I also would like to make sure that you leave here knowing that there is the beginnings of a plan for all of us to improve our health and well-being. It is not my plan, it is not the Virginia Department of Health plan. It needs to be our plan. And it's waiting for your input. It is now up on the Virginia Department of Health website. I'll show you pieces of it. But I would like to invite you to be active participants. In fact, you're already doing much of what needs to be done, but what I'm asking you to do is align your effort. I'll come back to the alignment piece, and we'll discuss a little bit about some of the roles that you individually and then collectively as an association can play. So just take a moment and imagine. Think about your communities. If you had a clean slate, so to speak, what would you do differently to make sure that people could make better, healthful decisions, to have the kind of health behaviors that make a difference? What would be different physically about the environment? How might walkways, sidewalks, roadways be different to allow children to get safely back and forth to school and move instead of riding a bus or taking a car? All those things matter, and I'll come back to them. But if you don't imagine what it could look like, it will never change. It will never change. We are creatures of habit. Anybody agree with me? We are creatures of habit. We get comfortable in our day-to-day, and it requires energy to make a change. But it also requires a vision. You need to know where you want to go. So this is really critical that each of us imagine what it could look like. Because if we can't see that in our own minds, we will never get there. And I'm hoping as I go through some of this information that you will start to think about how things might be different to get better outcomes, and then what you individually and we collectively can do to get there. It is going to require that level of action, and the window is open for us to do that now in a way that I do not think it will continue to be. And when you walk over to the General Assembly, keep those visions in mind, because those policies need to help us get there too. Okay? Anybody imagining? Can you see some changes that need to occur in your own mind? This is really important. If we don't imagine, if we don't visualize, we will never change. And I hope that what I show you demonstrates we must change. We must do things differently. And we can do it. Okay, I need to know that you're awake. So if I say something that resonates, would you let me know? It's short of audience participation. It's really critical. So two things I'd like to say. One is, feel free to stand up if you need to, if you can, if you want to, because sitting for a prolonged period of time is not good for our health. So stand up when you need to. If you need me to make you do that, I'll help to do that. And please shout out, say something, so I know that I've struck a nerve. It's really critical. I can't have you sit there quietly as we go through this. I don't think Emily Couric would want that either. So what you're seeing in front of you now is a framework for what I think of as alignment of effort. There's plenty of effort out there. If Virginia is going to be healthier and well, all 8.4 million and all of our visitors who pass through, then there's some underpinning that needs to occur. And we've framed this as a tree, the tree metaphor, with the roots being the community, where we live, work, and play, or go to school. Having what we call a healthy, connected community is the foundation for all of us. It's where policies are made, and policies are made based on relationships and the will of the people willing to do the work, and the ability of the voices to be heard. So think about the healthy, connected community, not just the natural environment, but also the built environment, our streets, our buildings, and the social environment. All of those matter, and they make a difference. And you'll see critical differences throughout Virginia. The other thing, the trunk of the tree is a focus on our children. If all of our children had a strong start, we could break the cycle of disease burden that we see, and you will see some of that data. So investing in our children, and these are important policy decisions, is critical if we're ever going to see change. And right now, you'll see some of the trends. The trends are not good for the next generation. From that trunk come two important branches. One, where many of you live, in the system of health care. So how many of you think that we have a system of health care? Okay, some of you do, but many of you, either you're sleeping or you're not aware. We have work to do there. A system of health care is one that is built around people to make it easier for people to get what they need at the right time, at the right place, at a reasonable cost. Think about it that way. There's great work being done around the Commonwealth. More needs to happen, and access is a critical issue. Access is a critical issue. The other branch we called preventive actions, but you might think of that as creating a culture of health. Prevention everywhere, making it easier for people to do healthful behaviors instead of harmful behaviors. And that, as you imagine your communities, if we really wanted prevention to be everywhere, we might redesign our communities to make it easier for people to move around as a default, to have access to healthy foods. All of those things can be influenced through design, and that's what I'm asking you to think about. This is very consistent with the Robert Wood Johnson Foundation's Culture of Health approach, where prevention isn't just in a medical facility. It isn't just something a provider does for you or to you. It is in our culture. It's embedded. So those foundational pieces we've created metrics for to help us know where we're at and where we think we need to go, with the idea that the final outcomes, people being healthier and well, is the focus. In a nutshell, that is the plan for well-being. I'll come back to that. But that's a framework. The question for everybody then is, how can we align our efforts for these common outcomes that really matter? Outcomes that really matter to people. Not necessarily just a blood test, but am I better off? Am I well? Can I do my job? Can I go to school? All of those things matter. Can I age well? Can I remain in the community as I age? Do I have the supports I need? That's the framework, and it requires an alignment of effort. I do believe that despite what you hear about resource shortages, lack of money, we actually are very wealthy in this Commonwealth. We're in the top 10 per capita, and you'll see some of the statistics. We're not in the top 10 in terms of health. So I think there's a lot of resource that needs alignment to get better outcomes, and that's where we all come in. I hate to tell you this, but this slide, which was shown at the Joint Commission on Health Care a couple of years ago, about a year and a half, just emphasizes the point that health care alone isn't going to help us live longer and better lives. I'm sorry to the students. It doesn't mean that health care isn't important. It just means that all of these other factors that you see in the pie chart, behaviors, social environment, physical environment, and even our genetics, are even more impactful than health care. And the way I like to couch this is, as a provider, you can only be most effective if we're also dealing with all of these other issues. And most of those other issues are impacted by policy decisions and how we design our communities and our social relationships and support. So the opportunity for healthcare to do a better job rests with what I think of as a community support system that makes the job of the healthcare provider easier. Because so much of what happens to a person occurs outside the healthcare system, and what we want to do is help them stay healthy and maintain their health. And this is a really important concept that Robert Wood Johnson is focusing on, is starting to think about health as not only something that we restore when we lose it, but we retain and maintain while we have it. And as a society, we have not done that well. If we think that way, we would invest differently on the front end. I see a question out there.
Yeah, just looking at the slide, and we were talking about healthcare system, you want to have a great healthcare system, but it doesn't guarantee high quality of health. I'm looking at the 5 factors, and I think there's a 6th one that ought to be up there. And maybe most people won't agree with me, but I think a large reason why people don't take their health seriously in America is because we don't pay for our own health care. We look at public school, and when it became free, the quality of the education went down. When university became more attainable by creating the Department of Education and allowing people to borrow whatever they wanted to go to university, the cost went up exponentially, I think 1,000%, and the quality went down. And now with healthcare, we haven't had a free market healthcare system where people pay for their own healthcare in decades. We have an employer who pays our health insurance. Now we're looking at the very real chance that taxpayers will pay for each other's healthcare benefits. So if people aren't paying for the impact of poor lifestyle choices, how do we expect really to improve the quality of healthcare if we don't have any skin in the game?
So for those of you who might not have heard the comment, and thank you for the comment, really it comes down to the fact that we're not paying for health care. That should be another factor we look at, which is a nice lead into the next slide, is that actually we all are paying, and we're paying through the teeth, so to speak. When you compare the per capita costs for the United States versus every other state, if you can't see the slide, I will tell you it's easy to pick out the United States. We're that purple line spiking, and the light blue lines are life expectancy. So we're not even getting necessarily the value for what we are paying. So yes, we are not paying directly, and that means that we're less informed consumers with all of the issues around that. But ultimately, we are all paying the price because it's impacting so much else of what we can and can't do as a country, and it's critical. And I think the leverage point, to your point, is that people are looking on cost as a driver for making change. So even though we may not be paying directly, it is where the conversation's occurring in the policy arena, and it is part of the opening that comes in. But yes, we could be better informed consumers, and there might be a different dynamic if we were paying directly. There's another comment over here.
Yeah, I was looking at your previous slide going along with this, where it said 5% of the population or the individuals account for 50% of the spending. And those folks are going to be your frail elderly, your disabled, and they're not going to be the ones that can afford their own health care. But it also goes into your community support system. When you've got nurses out in the community actually doing that hands-on care with that 5%, there's not really a good community support system for those nurses that are working a little bit autonomously. And I know we're talking a lot about nurse practitioners' scope of practice, but even just the RN scope of practice out in the community is essential, in that if I'm working with somebody who's a frail elderly and I have to call the physician 5 times, he's eventually going to say, go to the emergency room, which is going to drive up that healthcare cost.
So I didn't plant these questions, but they really...
I'm just going to jump in for just a second and ask, because we are recording this session, and also we want everyone to be able to hear the questions. If you have a question, please approach a mic. We have 3 of them throughout. Thank you.
Good. And I think this is great. This is the kind of interchange we need. So the question really was related to the community support systems or lack of community support systems, particularly for nurses trying to do this community work, and people ending up in the emergency department because there aren't the opportunities. Well, this is actual real data from Virginia. We now have an all-payers claim database. So at least for people who have some form of insurance, we can begin to get data. And this is important because it doesn't provide data for people who are uninsured or self-pay. But we can see, this slide is telling us that probably about half of those visits to the emergency department are potentially unnecessary, not to mention unavoidable, which many of these in the whole pie chart. But it gets back to this issue that we are not investing in the community support systems to assure, as you mentioned, the frail elderly who make up a huge chunk of the health care cost, particularly that end-of-life cost. can stay in the community and have the services that they need. And so policymakers are starting to figure out, and unfortunately less so in Virginia, which is why they need to hear from you, but they're starting to figure out that maybe better investments are assure housing, assure community support systems, wraparound services, and then people get better care earlier that's less costly, and it pays for itself. And by the way, the outcomes that really matter, people being better off, also improve. We need a dramatic step back and a rethink on how we invest our limited resources. And we're in a really difficult place because we've got a huge burden of illness. We have to deal with that. And we have to break the cycle. And this is the policy challenge that's out there. Nobody has the answer, but it requires investing in both arenas and figuring out how to get there. So I agree wholeheartedly, and there's some work being done in Virginia to try to invest better in the community piece. I think it will make providers do a better job. So there's no magic here, but I think if we really want all people in Virginia to have a greater opportunity for health, then as we've said, we have to factor into the policy decisions all of these other issues. Because health now, if we want to maintain health and not just restore it when we're ill, requires investment in arenas we haven't invested our health dollars. This is a tough sell, but this is where we need to go. I talked about investing in children. That's critical. We're looking actually at educational objectives and outcomes as a measure for whether children are healthy. And I was hoping that the First Lady would be here before me because she's been a great advocate of dealing with hunger, particularly childhood hunger. And with her help, we've impacted the well-being of many children around the Commonwealth who now don't have to go to school hungry. But if you're not well and if you're hungry, then you're not going to reach the educational objectives of kindergarten readiness or third grade. And so we use those in our plan for well-being as the outcome that matters, knowing that there are many other drivers that need to be impacted, and I'll show you that in a minute. And then I think the culture of health concept and the connected system of care are arenas that you as nurses can really help drive home if you begin to think about redesigning those communities. So let me tell you a little bit about the health of the people in Virginia. We're top 10 in per capita. Anybody know where we rank in terms of our health status? Some of you might have heard me speak, or others. Where do you think? Are we top 10? Yeah, well, on some metrics we are in the 30s and 40s. We are pretty much in the middle. Some of the major rankings put us 24 or 21. Here's one example, and you don't have to read this. I'll show you the top rankings. The green, which you may not see, is where we actually do better, and it's just a few areas. And the red is where we do worse. But for the most part, we're right in the middle. And in no uncertain terms, we're right in the middle because we have huge disparities in health outcomes among Virginians. Period. We have huge disparities. Unless we do something about the disparate outcomes, we will always stay in the middle. So where we do well, and these are things that we have less of than other states, but they're still issues, is the list you have here. And it doesn't mean that we need to do less work, but we have some things working. I will tell you we still have disparate outcomes in many of these arenas. And I'll show you the issue of drug deaths, which is an emerging issue with some horrifying data. And again, to tell the story of the people of Virginia, people in Virginia are dying at a young age of things like drug deaths. And it's very concerning. So here's where we don't do as well. The disparities in general. We still have huge issues with smoking, and I'll show you some of the child smoking data, which is still very concerning. And then some of these other areas where you would think, gee, we know how to take a blood pressure, we know how to treat blood pressure, but it's still an issue. In Virginia, as many other places, we have about 50% of the population who has hypertension either doesn't know it or it's uncontrolled. 2016, hard to believe that that's the case, but it is. And then others like infant mortality, I'll give you some of the data. Again, still huge disparities that we need to address. Now, I have some really smart people at the health department who've been working on an index to try to take all of those factors that impact health that aren't health care. So economic opportunities, educational opportunities, walkability of a community, food availability, all those things that matter, and map it to see if there are some places where you have a higher opportunity to be healthy because those things are better off, and some places where you have a lower opportunity. And guess what? When we map it, this is what Virginia looks like. If it's darker, that means that you have the darkest shades here, the lowest opportunity to be healthy. All of those things are against you. So even if you're well, it's going to be hard to stay well if you live, work, or play in these areas. In general, there's certainly more opportunity the further north in Virginia and less lower. But I'll take Fairfax as an example. We can break this down right to the census tract level. Even in Fairfax, one of the wealthiest areas of Virginia, we still have areas with very low opportunity. This is an index of indices, and since we're here in Richmond, I wanted to show you Richmond because I think Richmond is the most striking of all the places we've looked at. East and West Richmond. People who are from Richmond know this. Many of the health systems are doing good work in East Richmond to try to impact this. But this is just an index of those things that we think impact health. The interesting thing is VCU recently did a study looking at life expectancy based on where you were born in Richmond. And just what I showed you before, if you look at East-West Richmond, remember the darker green is higher opportunity for, in this case it's higher opportunity for health, and the lighter shaded areas is lower opportunity. And we see this, that the life expectancy issue matches perfectly, with almost a 20-year difference in life expectancy depending upon where you were born. Now, I just have to put a plug here for our market economy approach, because I keep hearing about, how many of you are from Richmond area? And you're hearing about grocery chains. So where do the new grocery chains end up? They end up at where the opportunity is already high. Why aren't they in the East End? We have food deserts in Richmond. So I think the concern for me is that the market economy, and I'm not speaking negatively about our economy in general, but we can't expect the market economy to solve these issues. These are huge societal issues that are going to take a different approach. And I think that's very true for health too. So that's just one small example. This is dramatic, and there's a huge history behind this for any of you who know Richmond history, and this is what we are going to have to deal with collectively if we want to make a difference. Healthcare is important, but it goes way beyond that. If we as providers want to be impactful, then we have to lend our voices and our actions to redesigning our community and our systems to actually make a difference here. If you want the same outcomes, don't do anything differently. Don't change. I guarantee you that the way it's set up will produce these same outcomes. That's what it's done, and that's what it will do. If you really want something different, we have to change it. We have to change it, each of us. Whether you live in East Richmond or West Richmond or somewhere else, it is going to require that concerted effort. Let me show you a little data about smoking, because smoking is the #1 public health impactful behavior that requires our attention. If we did something about smoking for all Virginians, we would have a huge impact in health, and I'll show you some of the data behind that. So right now, We're much better than we used to be, but we still have about 1 in 5 adults smoking. And I think what's concerning to me are some of these figures here for our youth. Yes, we're doing better. We do have a new hazard with e-cigarettes because we don't know enough about it, and there's a big uptake of youth with e-cigarettes thinking it's safe. We also think that hookahs are safe, and hookahs are not safe. So we have a lot of work to do yet. And if these numbers hold out, we're going to see that many deaths from people who start smoking now. We also know if we can help youth get to at least age 18 without smoking, their chances of smoking go down significantly. So there is tremendous work being done in Virginia, and the best work, and this is for all the student nurses, the best work is being done by the youth for the youth. The youth, when they have a voice, make the biggest difference. We, those older Virginians, or vintage Virginians, as I've heard it said, need to support them in their work. They need to be part of the solution.
Dr. Levine, in some of your...
I think they want you at the mic, Shirley.
In some of your material, it's been framed as nicotine addiction, and that really helps me reframe my thinking, because just telling someone to stop smoking doesn't really mean anything, but when I want to help you with your addiction, it really does help reframe it. So I really liked what you all did.
Thank you. I think words matter, and to Shirley's point, we have a lot of challenges here between cigarettes, e-cigarettes, other vehicles, and at the essence here, yes, we've got smoke with many of its carcinogens, but we also have nicotine, and e-cigarettes have nicotine, so they are hazardous, particularly to youth, to pregnant women, and we don't know enough yet about the secondhand aspects of it, but they do have nicotine, which is a poison. So I think it's important to keep that in mind. We do know there's some improvement in terms of households, either with or without smokers. This is some of the data here. We're monitoring this, and there's work to be done. Again, what happens locally is most critical, and everybody has a role, from a parent to an individual to you as a friend and a family member. And then infant mortality, I mentioned, is a significant issue still in Virginia, and it's mostly an issue because of the disparity that you see here. The top line is the outcome in the African American community, and I'm certainly not picking on the African American community, but if you think about it from the health opportunity perspective, there are many women who don't have the same opportunity to have a healthy pregnancy and the kind of outcomes. We all need to participate in getting that opportunity better, so that all women have the same opportunity to have a healthy pregnancy, get their children to term, and have a great start so infants can thrive. We've got some challenges in this geographically. This is what infant mortality looks like around the state, and the darker blue areas are where infant mortality is a bigger issue. So those of you who are from Tidewater, we have more work to do there, as an example. And then many of you know that infant mortality is also impacted by birth spacing. So issues like assuring access to contraceptives for all women is really critical, and particularly women after they give birth is critical, because look at the big difference just what getting women a year out from a pregnancy means in terms of infant mortality for the next pregnancy. Much of the mortality is in that close birth spacing. So here's a great example of why assuring that women have access to contraceptives when they need it can make a huge difference, not only for them and their families, but for us societally, because the cost of managing children in the NICU, for example, is huge, not to mention the cost to the individual and the family. And then an area that I don't have new data, this only shows till 2011, but what it shows you is that the top line of unintended pregnancy in Virginia, this is Virginia data, has not changed. And again, women primarily who live in areas with low health opportunity have the most issue in terms of unintended pregnancy. And if we don't see a change here, we're not going to see better outcomes in some of those other areas. And again, the other big driver of infant mortality is prematurity. And this is a graphic for Virginia data by race. And again, we see a huge disparity in the top line with the African American population versus other races in Virginia. If we can't help women get to the end of a full-term pregnancy, then we're going to continue to have the infant mortality and the disparities that exist. I'm happy to say the hospitals have banded together with many providers, and we're doing a great job in something that I would call a low-hanging fruit, preventing early elective delivery. There should not be early elective deliveries because the term elective means it's unnecessary. And we're making a huge impact there. Now we need to make a bigger impact on the issues related to prematurity, and one of those is smoking. The top line here, you see that women who smoke have greater possibility of prematurity, and if we could impact smoking and diabetes and other chronic issues, this is the number of infants who could be born at full term who aren't now and would have a huge impact. And if we continued that, if we could actually make a difference and improve the opportunity in our communities for women, then this is a survival curve. We could help women who have a greater chance of having an infant die before the age of 1 have the same opportunity as every other woman. And in this realm, if we could make it to 2020 and make a difference, we could save 700 babies who wouldn't otherwise have made it to their first birthday. And just help those women get to the type of opportunity that every other woman in Virginia has. So that's some of the data that I think is really impactful. And it shows that we can make a difference by focusing our efforts on the drivers of those issues and the importance of doing it in our communities where the disparities exist. If you want to come to the microphone. And as she's coming up, I'll say I want to cover a couple of emerging health issues. I mentioned it in the past and show you the story of Virginians through the data, which I think will alarm you as it did me. Yes.
Good morning. My name is Tess Earls. I'm a psychiatric nurse practitioner. One of the drivers that has not yet been mentioned is the impact of trauma and traumatic stress, which activates the HPA axis and is a leading cause for heart disease as well as hypertension, violence. It's linked to smoking, and if we don't address the trauma that is being that our children are being exposed to, especially children from impoverished neighborhoods, including the trauma of chronic poverty, we are going to continue to have these negative health outcomes no matter how hard we work at it from a medical end.
Thank you so much. A great point. I think that will fit in. That will fit in very nicely to the next section here, which is going to talk some on not only the drug issue, but the mental health issues. And the adverse childhood experiences, which I believe is what you were also referring to, has become front and center in our planning activities too. Again, it has a lot to do with this strong start for children. Some children don't have that opportunity to have the strongest start, but we can still make a difference and deal with those adverse childhood experiences and help them in a way that will significantly impact their later life. So thank you for bringing that up. So to that point, let me show you some data about things that are killing Virginians earlier. This, for those of you who are into biostatistics, this is years of potential life lost, and we use age 65 as the cutoff, so anybody in Virginia dying before the age of 65 is captured here, telling their story. And for many years, cancer, heart disease, and injury were kind of the top three. Many years back, it was heart disease, and then cancer. And for many years, including the most recent year we have data, cancer is the #1 killer of all Virginians. I think that's very relevant for this particular talk. But in this specific piece, I want you to notice cancer here, #1 killer in 2013, and unintentional injury, which includes not only motor vehicle crashes, but drug poisonings and drug toxicity, for example. 2013 data. Now look what happens in 2014. And I don't have the 2015 data, but it would probably look even worse. But let me show you how we're doing in terms of drug overdose issues. And again, this is only till 2013, so many people think about this as an issue in western and southwestern Virginia, which is true. It's highlighted. But over the past couple of years, we've had another concern called heroin. And heroin is primarily a big city issue. And so when I map the latest data, it's going to look a little different with much more big city areas that are highlighted as concerning. And it's going to do that because of the issue around mental health and substance abuse. This is just hospitalization rates, again, only till 2013, but I can tell you we've looked at some of the more recent data, and you can see how that curve takes off. It is unbelievable, and I know many of you are experiencing that or are touched in one way, shape, or form. To the point about mental health, adverse events, stress, we as a society have to deal with this. We as Virginians have to deal with this. And I'm very concerned that the stigma of mental health and drug overdose is getting in the way. And who better but nurses and healthcare providers to make that point, that these are medical conditions that require medical care and approaches just like we deal with any other problem. We cannot ignore this any longer. And we cannot write off a whole segment of the community, which now includes our friends, our families, our neighbors, our coworkers, everybody. Everybody in Virginia is touched in one way, shape, or form. So this is a huge policy issue. I'm not advocating to you, but I'm sharing with you the story of the people of Virginia, asking you, if you haven't already, to help take action and make a difference. We all need to work on this. So I've told you the story of Virginians. It's not a pretty story, and there's a lot of history. But we could write the next chapter, and the future could be much better. But if we do nothing, I guarantee you it won't change. The outcomes will be the same. I told my staff when I took over a year and a half ago that if you want everything to be the same, just keep doing what you're doing. But if you really believe that the people of Virginia deserve better outcomes, we have to step back and think differently about how we do our work. And I hope when you leave here today, if you haven't already, that you will step back and take a new look at your work. And for the students, please take a look at your role as nurses and what that means for the individual patients and the collective patients. We really need to work together. I know that my time with you is winding down. I wanted to quickly show you the plan for well-being, but I wanted to ask you to go to the website and to look at it. There will be opportunities locally and regionally to be critically involved in this process. And over the course of this year, which I think is a pivotal year, if you're silent, if your voices are not heard, then we're in big trouble. So I'm giving you permission and asking you and begging of you to be an active participant in this. I think it's not rocket science. We're setting up a framework, but it really comes down to knowing where we are, and that's where the data, telling the story of the people of Virginia, planning, which quite frankly we have not done well in Virginia. We have not planned. We've not been intentional, and we need to align our efforts and then focus. We can't do everything, so let's pick one or two things that we can do. Let's pick one or two things we can do over a year. Perhaps you as an association can pick one or two things that you will champion. Make it clear where you want to go, Think about, visualize what it looks like, and then make sure you get ongoing feedback. It's not rocket science, it's just a continuous improvement process. And I think for those of you who are very focused on clinical, I want you to realize that this pyramid, which was put together by Tom Frieden at the CDC, represents that all of these aspects of the pyramid, which touch lives differently, are important and need to be embraced. So you may be at the top of the pyramid doing individual counseling, education, or clinical interventions, but that is all going to be influenced by the socioeconomic conditions of the person you're caring for and the policymakers and their decisions. And so we need to make sure that if you take a slice through this pyramid, all of the activities at every level are aligned to get the best outcome for the people of Virginia. That's the alignment piece of it. It's not that one matters more than the other. It's just that if we don't put emphasis at the bottom too, we're not going to make a difference. So the approach of the plan is very simple. We have to deal with the burden of disease from what you heard about the story of the people of Virginia. But I think it's about access for people, as I said, the right care at the right time at a reasonable cost. I'd certainly much rather that people at a medical home, that they could get their issues dealt with early than end up in crisis in the emergency department. And that's for a medical condition or a psychiatric condition, doesn't matter. To do that, though, we're going to require those community systems that were mentioned before. So that's where we have to break the cycle and create the culture of health in the communities, and that's where the rethinking and the redesign of communities come in, and every one of us has a responsibility there. And then, as I mentioned, thinking about health differently. And I think you as nurses know better than anybody that we have a huge opportunity to retain and maintain our health if we just put some emphasis there. So in a nutshell, that's what the plan is laid out for. You already saw the framework. And I'm not going to read all these, but it actually started because the Joint Commission on Healthcare, members of the Senate and the House, asked us at the Health Department to lead the charge and create metrics that would help us know in Virginia how we're doing. So these are the metrics. They're in the plan. And when you look at these, you'll see, as I mentioned, they're not all health care or health outcome metrics. They really run the gamut, and we tried to focus on things that really matter to people. But you see the big bucket areas, and I'll just quickly give you a snapshot of what some of the focused goals look like for the coming years. We have big aims. In this one, this is the healthy, connected community. We know that economic stability is a huge driver, and we also know that we need to work together around community health, and I'll talk in a moment about what that means for all of us. Here's some of the drivers. The drivers are where we can make a difference, and something for you to think about as you go through here. And we'll have better data as we do this, so we know which drivers at which time might be most impactful, and what is the evidence base in order to make an intervention around some of these drivers. We've got a growing evidence base. I think it's incumbent upon us to use that too. So for a strong start for children, here are some of our aims and particular focus. And for preventative goals, and then systems of healthcare. And I'll just point out here that having that integrated medical home is really critical. We've got a long way to go, but there is some good work being done there. And on the bottom, you might notice that healthcare-associated infections is a focus. And the reason for this is that it's important. It is something that's being worked on. It is a patient safety issue. and it requires a system of healthcare to actually do. So a hospital, providers, long-term care, public health, and others have to work together. If we can create the model, then we can replicate it regardless. We actually are focusing on C. diff, but it doesn't have to be C. diff. C. diff is just something we happen to be working on. So for us, it's all about creating the systems to move forward. So we want to go from 24 to 1. It's messy. Public health is in the middle, but that doesn't really mean anything. I think we just get in the middle of a lot of things. It's going to require many partners. Each of you have links to many of these partners, and we need those connections. Each of those lines represents a relationship. Remember, it's through the relationships that things happen. And that's where we need to focus, is creating the kind of generative relationships where both parties are better off. We want to align our efforts. We can't afford to be doing things in parallel, one side not knowing the other. And I think if you're really interested in this, I would ask you to get involved in local community health assessments. Have any of you been involved in local community health assessments? Okay. So if I come back in a year, I want to see every hand up, because at the end of the day, the community, each community has to come together, and we have to know where we are before we can figure out where we want to go, and then understand what the gap is. Understanding the gap means knowing what our assets in the community are, what our resources, and who can do what to fill those gaps. The health department is playing an assurance role, making sure that in every one of our 35 health districts, by the end of the year, there will be a community health assessment process. The nonprofit hospitals have to do this for IRS purposes, so that's already happened in many areas. We've partnered at the health department with many of them, and we can continue that. We need to assure that every part of Virginia has a community health assessment where the community comes together. So please look at that. If you're not familiar, you can go to our website and look up the local health districts and connect. There are many healthy community type activities going on, and this is a great opportunity to be involved. And it may not be through this process. It could be done in your organization, in your healthcare system, through your church. Many churches and synagogues and other religious entities are getting involved in this too. They can make a difference. And then other nonprofit or other organizations. I would tell you, to make this doable, just focus on what really matters to the people in the community. Pick one thing. Try to align it with the plan for well-being, and I think will be support and resources to do that. We're making as much, if not all, of our data available to you, which is critical. If you go to the Virginia Department of Health website, on the front page, there is a new data tab. I love it because I couldn't even find our own data. Now you can find our data, and we're going to keep working at that to make it easier for you. We need the data because, again, that is the story of the people of Virginia. These are all of our health districts. All of these people are ramping up to do this work with you, not by themselves, and support it if it's already being done. We don't want to reinvent the wheel. And at the end of the day, again, it's not rocket science. I think we have to improve access. We have to create that culture of health with prevention everywhere, and we really have to think about health differently. Because when we do that, we see the opportunity, and I'm hoping that you'll take that vision of your community and you'll tweak it, and you'll talk about it, and you'll work with it, and help us get to become the healthiest state in the nation, because we can do it. We can be there. With that, thank you very much. I've appreciated it. You're all way too quiet, but
Dr. Levine.
I wish you a great conference. I think we have a question.
I think as nurses, we're all educators. We all want to educate our patients, but it's really difficult to teach our patients now about what they should be doing, what they need to do, when everything is driven by patient satisfaction scores and times. How do we fix that?
All right, I think you've touched a nerve here.
Sorry.
So, I think at the end of the day, we're all focused on the experience. The experience matters. And the question that I would ask, and I think this is where the community health assessment comes in, is have we really asked what matters to people? Because I think if it's important to people, then we ought to be trying to measure that in one way, shape, or form. I'm not convinced that the whole approach to patient satisfaction has really taken that into account. I suspect that having worked in large hospital systems and realizing how busy we all are doing the work that we need to do, that many people coming into those complex systems feel overwhelmed themselves as a patient. And so the patient satisfaction approach has been an effort to try to re-engage people so that they feel they have some control again in what's going on by eliciting their feedback. I think at the end of the day, we really need to focus on the relationship piece, which you all know even better than I do, and that as we think about things like patient satisfaction, it's not just about a survey, it's about every part of the system and its design around the person that it's intended for. I would say that part of the problem and the reason perhaps we're where we are is because the systems we've set up were not designed for the patients. They were designed for the